Well, we're going to change gears, and we're going to talk about some patients that it makes a difference what we do. Now, in high-risk patients, we have to sort of get in our mind exactly what we're talking about. And by high-risk patients, we're talking about the kind of patients that I often see and Dr. Cohen sees. We're not talking about patients with just bunches of lymph nodes and small recurrences. We're talking patients like this with a tall cell variant, negative scan, FDG positive. We're talking about patients that even though their tumors grab onto radioactive iodine a little bit, over the years they develop these huge metastases in the pelvis, huge metastases in the ribs that require tyrosine kinase inhibitors. Or patients like this that we had followed for several years from 2006 to 2010, and her pulmonary lesions were slowly getting bigger. She'd seen all of our medical oncologists. She gives me a hug at every visit and said, "You are not giving me any of those pills. I'm going to see the Phillies play in spring training in Florida every year." And then after several years, the thyroid globulin continued to climb, and she developed brain metastasis years down the road. These are the high-risk patients that we need to put more of our efforts on. If you look at sort of how these came out, these are the high-risk patients in every system. Whether this is high risk from the European Thyroid Association or the Japanese Thyroid Association, the Mazaferi days, these are patients that we've agreed for the last 50 years are high risk. And these are patients with gross extrathyroid extension. There's a really nice talk this morning about that minor extrathyroid extension that honestly is a minor risk factor. In the new guidelines, I actually tried to get that moved to low risk. That almost got me thrown off the committee. So I gave up, and it stays an intermediate risk, but I moved it really close to low risk. So it's right on the border down there. But these gross extrathyroid extensions, particularly if we don't get a complete tumor resection, that's when we're in trouble, because those are not tumors we can rescue with radioactive iodine. As somebody said before, when Gil presented us a tumor that was in a young person that was growing into the trachea and extrathyroid extension, we know that's not a classic papillary. That's a tall cell, that's a columnar, that's something that's going to be a bad actor. And then we also use this inappropriate thyroid globulin elevation. There's a real move to use that thyroid globulin about 6 weeks after the first thyroid surgery to help you risk stratify. Because if somebody looks like they're low risk and they've got a thyroid globulin of 1,000, we've got a problem, right? And that would tell us, well, maybe we need to do some more studies. They're not really low risk at all. If you look at what happens to these high-risk patients are high risk for a reason. Their likelihood of having persistent or recurrent disease is 85, 86%. Shaha, my surgeon, told me years ago I didn't need to bother with a risk stratification. He could just call me from the operating room and tell me who was going to do bad. And he's largely right, because it's that gross extrathyroid extension, bad disease. And furthermore, we don't do such a great job with these patients. If we look at our high-risk patients, only about 10 or 15% of them actually go into remission if you define that as undetectable stimulated thyroid globulin, and over 72% have structural persistent disease. This is the group of patients that's a problem. Their recurrence is not their problem. Persistent progressive disease is their problem. So you got the picture of high-risk patients for me? One of my first thyroid cancer fellows saw her first patient with me years ago, and it was a young person that had 25 positive lymph nodes and N1B disease for papillary cancer. And she came back and said, "Let me tell you about this high-risk patient." And I said, "Okay." And then the second patient she saw was a metastatic follicular thyroid cancer patient with spine mets and hip mets and a brain met. And she came back and said, "Before I present this case, I would like to change the risk of the one I just saw. I now understand high risk." True story. That was from one of my Canadian fellows. Now, how do we do the follow-up? This comes up a lot, and people ask, how do we do the follow-up? In the new guidelines, the follow-up is going to be risk stratified. And most of us are comfortable that when we do that first follow-up for low and intermediate risk patients, it's probably about every 6 months for a year or two. Do an ultrasound at 1 year and maybe 2 years. This is the follow-up that we're kind of comfortable doing. It probably is still a little bit of over-testing, but patients seem to feel comfortable with that. It seems reasonable. But now when we start talking about these high-risk patients, there are going to be other tools that come in. You have to be careful with the pendulum swinging too far, because over the last several years, I've seen some high-risk patients followed only with TG and ultrasound. You're going to miss a lot of disease in these high-risk patients. You have to know that in the high-risk patients, you got to think more like an oncologist. I tell the endocrinologist, take your endocrine hat off and put your oncology hat on. In these high-risk patients, you have to think about this disease like Ezra and his colleagues, where you're thinking about this as adenocarcinoma that just happens to come from the thyroid. That's the way we have to think about it. And so how I do CT scans and PET scans is going to depend on all of these features that develop over time. What's the location of their disease? Somebody with something in the brain, I'm going to follow a lot more closely than a little small nodule in the lung with lots of lung around it. What's their rate of progression? What's the TG doubling time? Being aware that these high-risk tumors, while they usually produce some TG, it'll often be inappropriately low. We know in classic papillary, if you have a TG of 5, it's probably in the neck. But in the poorly differentiated, a TG of 5 could be a mass in the lung, could be a liver metastasis. So you can't trust that TG gives you as much information. It's really unusual to see one that doesn't make TG, but they just make inappropriately low. And then, of course, PET scan can help us determine the frequency of follow-up as well, because that's a marker of aggressivity. Now, so some people get into the high-risk group because they start high-risk. Other people fall into the high-risk group over time. And we began writing years ago that you had to adjust your risk stratification over time. Here's the classic example. This is a 22-year-old female. She had a total thyroidectomy and neck dissection, had a bunch of positive lymph nodes. So she would be ATA intermediate risk, with the risk of recurrence or persistent disease of 30 or 40% because of the big lymph nodes. Her risk of dying of thyroid cancer is less than 1%. But when she comes back at 6 months, this is what you've got. An ultrasound that's negative and a TG of less than 1. Is her risk of recurrence still 44%? Probably not, right? Now, I knew I was coming to Israel, so I ordered a bunch of tests. Ultrasound negative, stimulated TG. I've never done a diagnostic scan in TG. I did a diagnostic scan because I want to feel loved. A diagnostic scan that's negative. Is her risk of recurrence still 44%? Now, you know this answer now, right? Because we know once we have a stimulated TG of less than 1, the recurrence rate is what? 1 or 2%. So she went from 44%. Now, look theoretically what would have happened if she went the other way. We started in the same place, but at 6 months, she's got a neck full of lymph nodes. She's got a TG of 68 and pulmonary nodules. Is her risk of recurrence still 44%? No, it is 100%. She's recurring. Is her risk of death still less than 1%? Maybe not, right? Now, this is an unusual case. There's not many of these intermediate risk patients that follow. This was a real case, and a year later, this happened to her, and she died about 4 or 5 years later. We knew 6 months into her course, what we thought was intermediate was actually high risk, and we upstaged her at 6 months to high risk. And I followed her just like a high-risk patient. You with me on that? So what we did, and you'll see this in the new guidelines, these actual wordings are used, we needed a way to describe how did people respond to their therapy. Now, there was 2 strategies. We could have made a low-risk patient and changed them to high, or a high-risk patient and changed them to low. That seemed kind of confusing. So we said, let's leave the ATA low, intermediate, and high, just like we do T&M stage. I know theoretically you can change your AJCC stage, but none of us do it. Whatever stage you start with, whatever ATA risk you start with, and then let's define some new words to describe how's the patient doing over time. Out of these 4 boxes, which one do you want to be in if you have thyroid cancer? That's pretty easy, right? I haven't even shown you the definition yet, and you want to be in the excellent group, right? So the excellent group is essentially remission to oncologist. It's no evidence of disease. Now, you'll see in this excellent response, there's not a magic TG number, because the TG that defines an excellent response is going to be different if I do total thyroidectomy radioactive iodine. It'll be different if I do total thyroidectomy without radioactive iodine, and it'll be different if I do lobectomy, right? So the term excellent is what we as a community decide means you have no evidence of disease. After radioactive iodine, it's essentially a stimulated TG less than 1, because that's what we all accept. This biochemical incomplete means that they've got some leftover thyroglobulin, but we can't find any structural disease. The structural disease is what we're talking about this morning. They have disease on an ultrasound, on a CT, on some imaging. They have structural disease. And then the last group was, have you ever flown into like Chicago O'Hare Airport? Have you ever tried to get into Chicago? And you know how it always looks like you're about to get there early? And then you circle the airport for an hour and a half until they let you land? This is my Chicago O'Hare circling. So the indeterminates, I can't really decide if you're cured yet. Maybe you've got a little nodule on the thyroid bed. Maybe you got a little granuloma on the chest CT. I don't want to call you excellent because I throw you out of my clinic. I don't want to have you tell you have disease because then you may want me to do something. So we'll make up some term called indeterminate that patients don't understand, which basically says, come back and ask me again in 6 months. I mean, I'm a dad. It's like, go ask your mom, right? Go ask your mom, come back in 6 months. That's the way we'll go. Now, if you look at how all of this works out, the people that get in trouble are the people that have the structural incomplete response. That's where essentially all the deaths are. We spent all morning worried about thyroglobulins of 1 and 5 and lymph nodes of 0.2. None of that matters in the grand scheme of who's dying from the thyroid cancer. And as somebody showed this morning, we've got the good news and the bad news is we haven't changed the death rate at all in thyroid cancer. We have the same number of people dying of thyroid cancer each year. It's because we haven't made a substantial impact on this distant structural group, which includes largely these patients with distant metastasis and these older patients with persistent disease in the neck. So when you look at how a patient's going to do, this response to therapy makes a huge difference. You'll find all this in the guidelines where we say if you have an excellent response, your risk of recurrence drops to 1 or 2%. And so the follow-up should be different. They don't need intensive TSH suppression. They don't need 100 ultrasounds. If you keep ultrasounding these people, you'll find far more false positives. I work in Manhattan. I tell the patients if they keep seeing me every 6 months, they are more likely to die in a New York City taxi than they are from their thyroid cancer. And I have to report overall survival, so you cannot come back and see me. This is about my studies. This is how we do long-term follow-up. These structural incompletes, this is where we had a lot of the discussion this morning, right? So in the structural incompletes, if you had asked me 10 years ago, I would have said they all needed to be treated. They all need radioactive iodine. They all need surgery. Now, we've tried that for 10 years, and we realize it's not working so well. And so now we're having discussions about some of these get observed, some of these get treated. This is really a critical decision, as Eyal was saying. We don't want to pull too far on this structural disease group because this is, in fact, where our deaths from thyroid cancer come from. If I pull back on a low-risk patient, it honestly just doesn't matter at all. But now that we're talking about watching structural disease and intervening, it's critical that we sort of figure this out to make sure that we do appropriate therapy but not hurt too many people either by over-aggressive watching or over-aggressive treatment. You'll see in the new guidelines, the long-term follow-up now is no longer based on whether they're low or intermediate or high risk, but rather based on their response to therapy. So in the guidelines, when they should be published this summer, I know I've been saying that forever, Thyroid has them right now and is finishing the review. Honestly, I can't stand to read them one more time. I'm about to go on strike and quit. I can't look at them one more time. What you'll see is the early follow-up is going to be based on whether you're low, intermediate, and high. And then after the first year or two, your long-term follow-up is going to be based on your response to therapy. So that if you have an excellent response to therapy, we're going to say, do the thyroglobulin every 1 to 2 years. Do the ultrasound every 5 years, and don't do any of these other studies at all. Bring the TSH back to 1 or 2. Stop hurting people and follow over time. If you have sort of the indeterminate, we're going to watch a little closer. If you've got some low-level TG, we're going to watch a little closer depending on if your TG is going up or down. And if you have structural incomplete, that's the group that we're going to keep watching, as we talked about, with doing the frequency of follow-up and interventions based on how they're changing. Now, there's one caveat I always throw in here for the medical oncologist. is this excellent response works great in everybody except the high-risk patients. If you have an excellent response and you're low or intermediate, your risk of recurrence drops to 1%. If you started as high risk and get an excellent response, your risk of recurrence is still 15%. So you'll see in the guidelines, we say if you have an excellent response, back off completely unless you're high risk. There are not many high-risk patients that get an excellent response, but the few that do deserve a little more TSH suppression, a little more follow-up for that first 4 or 5 years. The reason for that is those guys get inappropriately called excellent because they're not making much thyroglobulin. And so they get inappropriately classified. So the excellent response, you're going to be able to way back off on the patients, but keep in mind if they started as ATA high risk, keep an eye on them just a little bit closer. Now, what are the treatment options and how do we sort of walk through this paradigm? Well, we have lots of options, including TSH suppression, radioactive iodine. We've got localized therapies we can use. We've got systemic therapies. I'm going to take you right up until lunchtime and stop with the systemic therapy so Dr. Cohen doesn't think I'm about to give his talk. I can't because I don't understand any of that stuff he's going to talk about. So he's going to talk about tyrosine kinases inhibitors and how you make people feel better. And if you give them a drug and they have a side effect, good news, if you have the side effect, your drug is working better. Don't buy a used car from oncologists. They're a tough crowd. What we have to deal with is before we get to there, how do we as endocrinologists or surgeons, when we're facing these patients, how do you know who goes first? What do you use? Here's just a classy example. I saw this guy a month ago. He's a 67-year-old physician, pulmonary doctor, and finally came in because his morning swimming laps were starting to be bothered. Because he was a doctor, he was able to get an ultrasound, a PET scan, a biopsy, and my phone number all within 24 hours. It was amazing. So this was as close to a thyroid emergency as I ever get. He's got a big 4-centimeter lesion in the acetabulum here that's getting dangerously close to that. He had a biopsy that was follicular neoplasm. I thought at this point we probably didn't need fancy molecular testing, right? We kind of figured out this was follicular cancer. His next CT shows this huge mass wrapping back around behind it, and his PET scan is markedly positive with multifocal disease. And so his question to me was, A, can I see you tomorrow? And B, should I come NPO? And what's the answer? Yes, you can see me tomorrow. I know, I can't stand the whining. I just can't take it. Yes, come see me tomorrow. So what goes first? Does he need thyroid surgery? You just going to let him break his hip? Fix the hip first? Fix the neck first? Send him to Memorial. That's what I would have done, except I was there. So how do we think through these issues? So a few months ago, somebody asked me to write, how the heck do you really think through this? So here, I think, is the thought process that I go through when I see these patients that present with distant metastasis or big unresectable disease in the neck. My first question is this in a critical location? Is this in a place that's going to break? Is this in a place that's going to cause cord compression? Are we going to fracture a femur? Are we going to fracture a humerus? If the answer is yes, we fix that first. Total thyroidectomy waits, radioactive iodine waits. We fix the brain metastasis. We fix the spine metastasis so it won't break. This hip was about to break. And so we had a big discussion on this particular case because he had a hip that was about to break and he had locally invasive disease. And oh, by the way, his ipsilateral cord was already paralyzed, as you would suspect. So is the disease in a critical location? That comes first. If it's not in a clinical location, then I'm interested in the distant metastasis. Are they RAI avid? If they are, then we head down the radioactive iodine trail, total thyroidectomy, radioactive iodine, whatever's necessary, low iodine diet. If it's not radioactive iodine, now I'm starting to think in Dr. Cohen's land, and I'm going to have to start thinking about some systemic therapy or chemotherapy. If they're symptomatic, that's going to make me lean toward doing something, because sometimes they don't have big mets, but they've got pleural effusions, or sometimes they've got lots of little disease and they're having pulmonary problems and dyspnea on exertion. That would make me want to treat. If they're not having any symptoms, which is most of them, then we go to size. If everything is smaller than a centimeter, I'm probably going to watch, and we'll do CT scans over time. If they're bigger than a centimeter, then I want to know if they're structurally progressive. And if they're not progressive, I'll watch. If they are progressive, I'll treat. So it boils down, I think, in my head to about 5 key questions. So when he wandered in the door, what I was trying to figure out is, do you have something in a critical location? He did in 2 critical locations, both the hip and the neck. So I needed him to see both my orthopedic surgeon and Shaha the same day, while the 2 of us figured out what was the right thing to do. In his case, we elected to put him on crutches because we didn't think he was going to break that hip anytime soon. We were worried that if the neck got much worse, it might not be resectable, so he went to thyroid surgery first, had gross extrathyroid extension. We followed that with external beam radiation, and that's about a month ago, and he's going to have his hip fixed next, which will be next week or 2. And then after that, we'll do radioactive iodine, because we had to deal with those critical locations first. Are they radioactive iodine refractory symptoms and structure? So I often get calls that say, can you rush and do a surgery? Can you rush and get total thyroidectomy radioactive iodine? And in these high-risk patients, we eventually get to that, but many times that's not the first step in the process. Make sense? So there's a process that we go through. So in his particular case, he had PET-positive disease. He had structural big disease. He was over 40 years old with macronodular lung disease and bone metastasis, and this is going to be what his overall survival is like. Despite being treated at Memorial, despite getting what we think is state-of-the-art care, he's not going to do well. And this is going to be a rough sort of 2 or 3 years for him to go through. So we became really interested again several years ago in how do we make radioactive iodine work better. And I'm going to show you the last piece of this, which is kind of show and tell, that says in these distant metastasis patients, yes, we can deal with external beam radiation, we can do radioablation. In the gross disease in the neck, we can deal with external beam radiation, big surgical stuff. But is there a way that we can make radioactive iodine work better? Because that was the original targeted therapy. Now, you know, over the years, there's been a variety of studies that looked at a lot of different agents to try to make radioactive iodine work better, and all of these have mixed with sort of limited success. This got back on our radar screen really the past 10 years with the observations that showed this pathway that you're familiar with, this MAP kinase pathway, which activates BRAF mutations and RAS mutations. In addition to causing thyroid cancer, if you activate BRAF, you actually shut off the genes you need for radioactive iodine. You shut off the sodium iodine symporter. You shut off TSH receptor. You can give all the thyrogen on the planet, but if there's no TSH receptor, it's not going to do any good. Remember, we knew from 15 years ago, these genes were not mutated, they were turned off. And we didn't understand why they were turned off. We have a lot of insights now to say, look, if that's why they're turned off, what if we target this pathway? If we used inhibitors of this pathway, and here's 5 or 6 that Jim Fagan and the lab has used at our place, and he in fact showed very, very nicely that if he blocked that pathway, not only could he treat the thyroid cancer, the BRAF positive tumors would shrink. If you looked at either their northerns or westerns or blots, you could actually turn back on their sodium iodine symporter and TSH receptor and make these tumors grab onto radioactive iodine again. So obviously we start in the mice. So here's some mice. Dr. Fagan has some wonderful mice that are genetically engineered. He can turn the BRAF gene on and off and cause them to get cancer and make cancer go away. His life's much easier than mine, because apparently if you have a mouse with thyroid cancer, we can cure that at Memorial. If you have patients, not so much. But if you have a mouse with thyroid cancer, ship them to Fagan's lab. So uninduced, oh, I forgot, this is being videotaped. Please edit that away, because otherwise I won't have a job. I'll be staying with my wife in Israel. Uninduced. So this is the normal thyroid that grabs onto radioactive iodine. You turn the BRAF gene on, they lose the ability to concentrate radioactive iodine. You turn it off, they grab back on again. Here's with an inhibitor. The BRAF gene is turned on. We use a MEK inhibitor, and it makes the tumor grab onto radioactive iodine again. Here's a BRAF inhibitor. The tumor's not concentrating, and now it is concentrating. Now, we were very fortunate that one of the tools that was being developed at Memorial is called I-124 PET scanning. Now, you know I come from Memorial. We have never seen a test that we think is too expensive. So we helped develop the world's most expensive radioactive iodine scan. It's awesome. Good luck trying to do one more expensive than this. I think we got it. It's an expensive scan. The reality is this will be able to be translated everywhere because it's a study that can be done on a standard PET scan machine. And I-124 is now commercially available in the United States. You can buy this. It works just like I-131 and I-123, but the difference is it's a positron emitter, which means the PET scan can see it. You're used to FDG PET scans where the radiologist gives you the SUV, right? What's the standard uptake value? Is it low or is it high? Think about having that exact same number with radioactive iodine. Now within each individual lesion, you know how much radiation is getting into that individual lesion, and you can calculate, will I give another dose? Does it make any difference? Is this tumor RAI refractory? So we use that tool. This is what they look like. It's just a fancy scan. We use that tool in this study that we published a couple years ago in New England Journal, a small pilot study where we took a bunch of our radioactive iodine refractory patients that had all had 2 or 3 doses of radioactive iodine. We gave them selumetinib, which is a MEK inhibitor. It blocks the pathway that we'd shown in the mice that we could make the mice grab back onto radioactive iodine. And in our patients, 12 out of the 20 patients actually grabbed back onto radioactive iodine. Now, there was a few of them that grabbed onto just a little, not enough to be a treatment effect. So 8 of them, we thought we made them grab onto enough that it would be worthwhile going ahead and retreating. So this is selumetinib, not the way Dr. Cohen's going to talk about using these drugs lifelong or months at a time. This is a month's worth of treatment before the radioactive iodine to make the radioactive iodine work better. Here's just what some of the pictures look like. This is actually the first patient. We saw this one in our Tuesday afternoon clinic. Dr. Fagan looked down at me and said, nobody is going to believe us. This is too good to be true. They're going to think we PowerPointed this because we went from essentially no uptake to marked uptake. Here's another one. I'll barely see this little lymph node. Markedly uptake here, stuff in the lungs. Here's another one. This one is before and after. A little bit of uptake, now dramatic uptake. Here's another one. This was actually we were pretty excited about because this was a big bone metastasis. And at least our impression is that many of the tyrosine kinase inhibitors don't work as well in bone metastasis. So we would often put people on the tyrosine kinase inhibitors and they would fail in bone. This showed us a couple things. One, it made this bone metastasis really concentrate radioactive iodine. But even more importantly, if you look at the one in the skull, here's the metastasis. Before the selumetinib, there was a little bit of uptake here, but now after the selumetinib, there was diffuse uptake through the whole tumor. So we were getting not only increased uptake of radioactive iodine, but a more homogeneous distribution, which meant our radioactive iodine should have worked better. And in fact, we saw very, very good results. This is the actual individual lesions, each lesion from a single patient that showed how much uptake they had before the drug and then after. These had no uptake and then more. This actually is a way that we quantify how much did you make the uptake. Any red dot to the left of this purple line means we increased more than 100%. So these were not just minor uptakes. These were significant uptakes in lesional dosimetry. And of course, that translated to resist structural shrinkage of the tumors in the vast majority of these patients. We saw dramatic decreases in thyroglobulins. We had thyroglobulins in the 3 to 4 to 5,000 range drop to 9, 10, 15, and stay that way for a year and a half or 2 years. It truly restored the ability of radioactive iodine to treat these tumors. The unexpected observation, if you look at the top, most of them that responded were actually the RAS tumors. We had one BRAF tumor respond, and we were surprised at that because, remember, we went down this pathway because it was supposed to be a BRAF problem. We now understand that you have to shut off that BRAF pathway much better. That until you get it shut off like 90%, you don't restore the radioactive iodine function. And the selumetinib didn't hardly do that for us. So we've gone on to expand and say, this is a nice proof of principle. It's a nice start. How do we do better? One of the ways we do better is we've got a better MEK inhibitor. Selumetinib was the first one that we used. We're using trametinib now. It's a more targeted. It blocks the pathway better. So we think that's going to work better in the BRAFs. We're going to use vimurafenib, which is the melanoma drug designed specifically for these V600E BRAF mutations. And I'll show you, these were just a couple patients from 2 weeks ago. This is a RAS patient that's on trametinib, the new MEK inhibitor. We're seeing the same thing, a little bit of uptake to dramatic uptake. This one is another one on the MEK inhibitor, a little bit of uptake to more dramatic uptake. And this one's a BRAF inhibitor, a little bit of uptake to more dramatic uptake. So by targeting the specific individual gene in the tumor, we think we'll be able to tell you what's the best drug to use to redifferentiate the radioactive iodine. Now, up until now, we've largely used it in the RAI refractory space, but if it works in RAI refractory, you have to ask yourself, why wait until they're RAI refractory? Let's use these drugs to make our first dose of radioactive iodine in the metastatic setting work better, or the second setting. Why set yourself up for failure? Why treat and treat till it's no longer effective? So this is a trial where we're giving selumetinib to people with bone metastasis and lung metastasis that we know one dose is not going to cure them, and see if we can get better effectiveness. And then the last crazy thought is to take it all the way back to the adjuvant therapy setting. Because we know in these patients with N1B disease and big lateral neck disease has been showed all morning, their recurrence rates are 30 or 40%, and that's despite radioactive iodine. But we know radioactive iodine works in some of these people. So maybe you should do a study that says in these high-risk patients, with that very first ablation or adjuvant therapy dose of radioactive iodine, let's make that dose of radioactive iodine work better. And this is a randomized, prospective, international, multi-center trial we wrote about 3 years ago that's now about 2/3 enrolled to see if we can put more people into remission if we give you selumetinib before that first dose of 100 millicuries versus 100 millicuries alone. I really think in about 5 years, our preparation for most radioactive iodine is going to be a low iodine diet, TSH stimulation, and then probably one of these agents used for a couple weeks. I don't think we're really going to have to use them for a month. In the mice, 4 or 5 days works. I suspect we'll get this down to a couple weeks. You'll need to know the BRAF status of your tumor, the RAS status of your tumor, and then you'll say, for your particular case, you don't need it because it's just ablation and 30 millicuries is fine, or I'm doing adjuvant therapy or distant metastasis. In that setting, we know radioactive iodine works, but we want to make it work its best with low iodine diet. You'll have to use recombinant human TSH because all of these drugs that we're using had their toxicity profiles determined in euthyroid people. Nobody wants to give one of these drugs to somebody that's hypothyroid. So this novel paradigm will say even in these high-risk patients, you're going to have to use thyrogen to do it, but it'll come as part of the packaging. So I hope what I've left you with at the end of the day is some feel for how do we identify who these high-risk patients are. Many of them will declare themselves right up front. The surgeon will call you from the operating room and say, this is a high-risk patient, or they have obvious distant metastasis right up front. A smaller proportion will, as you follow them over time, move to the structural incomplete group, and you'll follow them exactly the same way as high-risk patients. And then as we deal with these high-risk patients, we really have to think about this disease like surgeons and oncologists. Think about these 5 questions. Is the disease in a critical location? Is it RAI refractory? Is the patient having symptoms? What's the size of the tumor? And is there structural progression? The answer to those 5 questions will tell you who goes first, what's the first therapy that needs to be done, what's the next, and is it time for systemic therapy? Thanks very much.